Okay, we're going to move on from the A&P centered content of this lecture into more surgery-specific information. We can only get more specific if you understand the A&P basics, though. So review, 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 review. Then learn something new and add it to what I need to know pile. Diagnostic procedures have been an important concept in all of our units thus far, and ortho is absolutely no exception. The diagnostic procedures performed the most within this specialty are by and large x-rays. X-rays are performed pre-op, intra-op, and post-op. Not far behind are MRIs. MRIs are extremely helpful because they can see past what the x-ray can see and show us tumors, or if cartilage is damaged, or if tendons are ruptured, or if ligaments are torn. These diagnostic tests can be such a help to you scrub techs because they can help you prepare for your cases. During total joints, x-rays can help the team template the approximate sizes of implants the patient will need. Fracture cases can be determined based on the type or severity of fracture present. One test that's not listed on your slide is electromyography, or EMG for short. Electromyography records and analyzes electrical activity in muscles. Some surgeries require an intraoperative EMG to preserve nerve continuity and muscle function. And don't forget about CT scans and ultrasounds, which can also detect tumors and abnormal bleeding, fluid, or fractures in the body. Your next slide touches on patient transporting and transferring, which was covered in depth during one of your 102 units. Some components particular to orthopedics include patients may arrive to the OR in traction, or they may have external fixators in place. Typically, the transfer of the patient usually does not occur until after anesthesia has been administered to lessen the patient's discomfort. Always remember to ask for help when needed. The patient's safety is of utmost importance, and you don't want to skimp on manpower when transporting or transferring a patient suffering from skeletal injuries. As you'll see on this next slide, patients are positioned using the standard OR table, but occasionally they may need to be positioned on the orthopedic or fracture table. Before we talk about the new information on this slide, let's review what positions we know we can expect in ortho already. We can expect patients to be in supine for anterior structures, or lateral for hip or shoulder procedures, prone for posterior anatomy like the hamstring or Achilles tendon. It's also possible to have the patient be in semi-Fowlers for shoulder surgery, but the position of the patient will ultimately depend on surgeon preference and patient ability. The fracture table is a special table as shown on your next slide that allows the patients to have their legs put in traction or pulling, which can reduce a fracture and reduce the amount of pain experienced by the fracture because the fracture edges are being pulled apart from one another. And the legs can be separated as well, and they will be secured, and then a C-arm can gain access and take an x-ray of the anatomy. Many surgeons will employ the use of a fracture table for hip and femur fractures. Finally, another positioning equipment that you may see in this specialty is a beanbag positioner. The beanbag positioner is great because the beans within the large bag will hold their shape when the air is suctioned from the bag, which in turn provides positioning stability because it conforms to the contours of the patient's body. Make sure there is always ample padding and insulation for the patient for positioning and to avoid inadvertent patient burns when using all this extra positioning equipment. The environment in orthopedic cases can be foreign to what you've experienced thus far in other specialties. It can be violent sometimes, it can be noisy, and there's often either a lot of bleeding or nearly none at all. It can be violent during total joints because they're sawing and hammering and whatnot. The volume of the room is often higher due to those saws and drills and hammers hammering. There's usually more personnel in the OR rooms, in the ortho rooms, because it takes more people to get the job done, and there's often medical industry representatives in the room too. The amount of blood loss will be directly related to the ability and or desire to use a tourniquet, because remember, blood is made in the bones, therefore we can't ligate it or cauterize it. So if you can't use a tourniquet, there will be bleeding. Recall from your 102 class the different hemostatic agents available and that warm bone wax can be extremely useful in stopping bleeding on bones. Do you remember how to get warm bone wax? We warm it up between our hands during surgery. In addition, infection control is extremely important in orthopedics. Much attention is paid toward preventing infection in all specialties, but particularly in ortho, because an infection in the bone, otherwise known as osteomyelitis, is very, very hard to overcome and can lead to major complications for the patient. Your next slide shows a cool picture of orthopedic hoods in use to prevent droplet contamination and circumferential head sterility. Take a trip down memory lane into Surge 100 and recall how many air exchanges typically take place in the OR. If you need help, head to page 57 in your book. Compare that to the number of exchanges in an ortho room with the laminar airflow. Big difference, huh? Next, we're going to move into fractures. On the first slide regarding bone fractures, notice we will be talking about fracture classifications. Don't confuse fracture classifications with joint classifications. We call them both classifications for lack of a better word, so note the criteria present on your slide. We need to know which bone is fractured. We need to know the pattern or type of fracture, the level of comminution, whether it's displaced or not, and even the way in which it was sustained. Was there a trauma or was it pathological? Knowing these factors will help the scrub tech make considerations regarding instrumentation, positioning factors, approach, all of which will completely determine the surgical procedure. In class, we will go over some scenarios and work through the information presented and the information you need to gather to make informed decisions. Your next slide comes directly from page 778 and shows you some common fracture patterns which are discussed beginning on page 775 in your workbook. You will want to know what a transverse, oblique, open, otherwise known as compound, spiral, impacted, comminuted fractures are. For your benefit, your next slide has some fractures that the book doesn't show you. Pause the video here so you can look at the nice big picture and jot down your notes and definitions on your PowerPoint handout. The next slide shows you the options for reduction and fixation. Note that there are two types of reduction, open and closed, and there are two types of fixation, internal and external. Don't, however, assume that open and internal will be automatically paired in your fracture procedures. In fact, each reduction type can theoretically be paired with either fixation type. When a procedure is deemed open or closed for reduction, that means whether an incision will be made or not. Green stick fractures in children are frequently reduced without making any incision at all, because their bones are still pliable and will allow themselves to be manipulated without internally doing so. Fractures that need to be reduced via an open incision will be considered an open reduction. When it comes to fixation, some fractures are externally fixated by way of an external fixator or casting material, while some are internally fixated with plates, screws, pins. For example, a wrist can be reduced via closed reduction with pin fixation. Therefore, that's a closed reduction, internal fixation. Each of these variations are usually abbreviated, and so that wrist example, the closed reduction, internal fixation, would be abbreviated CRIF, and it means that it will be closed, but there will be internal fixation. Another example is the open reduction internal fixation, abbreviated ORIF, and it means an incision will be made to reduce the fracture and internal devices will be implanted to fixate the fracture. We will do some examples in class to make sure you've got this concept down. Note the internal fixation devices are implants. Implants are regulated by strict guidelines, and orthopedic implants are used to stabilize fractures during bone healing. They can be made of the following types of materials: surgical steel, titanium, steel alloy, and bioabsorbable implants. Note that the first 3 implants do not absorb into the body, but the bioabsorbable implants do. These bioabsorbable implants are often used in rotator cuff and ACL surgery and take approximately 2 years to absorb. Pausing here.